Hi all, I'm Dr. Abubakar, Senior Resident, Department of Emergency Medicine. So now we are going to discuss about a protocol called RUSH protocol. So it is an emergency ultrasound based protocol to identify a sick scenario, and the objectives of the studies are just introduction about the RUSH protocol and basics of shock and the types of shock, because the RUSH protocol is basically it is needed in early identification of shock patients, and how we can perform a RUSH protocol and how we can interpret after the RUSH protocol, and what are the emergency interventions we are supposed to do after a successful performance of a RUSH protocol. So basically it is a RUSH protocol is introduced since 2006, and it is commonly used in ED scenarios. It is using to identify a shock patient in an emergency department. I think everyone knows about this shock. Shock is a scenario. It is a clinical condition when the body needs more than the resources are available, because basically the amount of energy or amount of substrate is needed for tissue, it is more than the requirements. So when the state is when the state happens, then the tissue will start to damage. So in an emergency medicine or emergency point of view, we have to identify the shock patient as early as possible, and we have to intervene and we have to treat the patient, otherwise the patient will lose the tissues. So the shock can be a localized or a generalized thing, because if it is a localized thing, we will call it as an ischemic event. Basically we know that ischemic events can be happen to the brain, we'll call it as CVA, cerebrovascular accident. This happened to the heart, we'll call it this is a acute coronary event, or mesenteric ischemia, we know limb ischemia. Those are the localized state of shock. But the ultrasound based RUSH protocol, we are try to identify the generalized form of shock when all the tissues all over the body is going to die because of their need is more than their requirements. So how we can identify that shock by using ultrasound? So for that purpose, we are using a ultrasound probe. We have two types of ultrasound probe that we are supposed to identify to tell you. That's some called phased array probes and linear probes. The phased array probes have a low frequency as compared to linear probes. So low frequency means it's have a high power of penetration, but low frequency it will show the superficial structures only. So we are using for the RUSH protocol, we are using a phased array probe. Basically this one is the phased array probe and this one is the linear probe. We are using for superficial structures, this one for deep structures. So for the evaluation of the shock patient, we have to use a phased array probe. We have to see that deeper structures to identify the cause. And basically we have based on the mechanism, we have 4 types of shocks. So first one is called hypovolemic shock, when the decreased volume in the intravascular state will leads to the shock. The shock is not just low BP. It is along with the low BP that the cell has to the cell need is not attained, then only we will call it a state of shock. So many patient we can see that patient is having hypotension. All hypotensions are not a shock scenario. The shock scenario that with the hypotension, the cellular metabolism it is also get to be dysregulated or can be damaged. The cells should be damaged. So that is a clinical scenario. There is a clinical identification as well as we have to identify with a laboratory investigation. Basically we are using as a lactate as an identifying marker. So then is something called a cardiogenic this is not the cardiogenic shock, where the issue it is basically it is in the pump. We'll call it as pump. It is cardiac issues. When the heart is not pumping adequately, then the patient will go into a state of shock. Then those cases we'll call as a cardiogenic shock. Then something called a distributive shock. In this scenario, the intravascular volume and the hearts are normal, but the distribution to the tissue will get disrupted. Basically, it is because of the increased capillary leak or the vessels are dilated. Those cases, the blood will not reach the tissue level adequately. So, these types of shock will call as a distributive shock. Then another thing is called obstructive shock. What is obstructive shock? So, obstructive shock, it is here the intravascular volume, the heart and the peripheries, that what vessels are normal, but here the heart cannot pump the blood because of the obstruction to the function of the heart. So, we will discuss the detail about the obstructive shocks types and how we can treat the patient also. So, based on the Rush protocol, so we are using a terminology we will call it as a tank, pump and pipe terminologies. Tank means the intravascular volume. So, basically by the IVC we can assess the intravascular volume, and the pump it is unless other it is a heart. So, heart is the pumping organisms or organ, it is pumping the blood into the all over the body, and the pipe is the path which is distributing the blood or the fluid into the tissue level. So, for assessment of Rush protocol we are following a mnemonics called HIMAP. So, basically H means heart. So, we are assessing the heart with ultrasound, and we are assessing the next one is I means IVC, we are assessing the inferior vena cava, and we are assessing the Morrison's pouch or the FAST. What we can use FAST is focused assessment of sonus certain trauma, but here we are looking for any fluid in the abdomen, and aorta, and we are looking for any pneumothorax, and we will discuss the detail. And this there is something called two terminology is also included with the Rush protocol. It is advanced Rush protocol, where we can look for the ectopic pregnancy as well as deep vein thrombosis. So, here is the way to look at the heart. Heart we can look at the three areas with the four views. So, three areas are, one area it is called the parasternal area, and another area it is B, it is called a subxiphoid view, and the C we will call it as a apical view. So, from these three zones we are getting a 4 images. So, first images we will call this as a parasternal long axis view, and the next images will call a parasternal short axis view. From the parasternal area itself we can get 2 images. Basically, it is called a parasternal long axis view and parasternal short axis view, and the second area, that subxiphoid area, where we will get a subxiphoid 4 chamber view, and from the apical view we will get a apical 4 chamber view. All the views will give an idea about the status of the heart. What all things we are supposed to look at the heart. This also it is should be objective. We are not supposed to look at all the things in the heart, but we have to, if the patient is in shock, we have to give some questions like how is the heart, how is the things. So, we have to, it should be an objective things to identify the pathology. So, here we can see a normal heart functions. So, here the cardiac functions are normal. I do not know how much you can identify, because it is by the experience only we will get an idea about the cardiac functions. So, it is a normal parasternal long axis view showing a normal heart function. It is a parasternal, it is a 4 chamber apical chamber view showing good LV functions. So, here you can see it is a hyperdynamic heart. Heart is pumping too fast. So, which all cases we will see like this? We can see in hypovolemic shock and early septic shock, and this is the stage of poor contractility. So, here you can see that as compared to the first normal cardiac function, here you can see that heart is pumping, it is very little. So, here also we can see that cardiac muscles are too apart, it is not at all attaching. So, it is because of the poor LV contractility power. So which all cases, which all type of shock will get to this type of picture? It is seen in cardiogenic shock, and will get in a late stage of septic shock. So what are other things we are supposed to look on the heart? It is called, so here you can see some this heart is dancing on the fluid. We will call this a pericardial tamponade. So fluid in the pericardial space, so it will obstruct the function of the heart. So that this called, we will call this a pericardial tamponade. So it is a type of obstructive shock where the heart is pumping well, but this pumping of the heart, it is compromised by the obstruction from outside. Is called this type of shock will called as a obstructive shock. And here you can see that, so here it is, this one is a LV and this one is RV. Usually we know that RV, LV it is bigger than the RV, but in this scenario we can see RV it is more than LV, and we can see the RA also it is getting dilated. So these cases also the patient will not get adequate circulation to the body. So this scenario we can see in pulmonary embolism. It is another type of obstructive shock. So in obstructive shock, so like pulmonary embolism, that blood will not pump out of the heart because of the obstruction above the heart in the pulmonary veins, and basically pulmonary arteries usually will be affected. This we can call it as RA-RV dilatation. When a patient is in a shock, we have to look for the, in the heart, what all things we supposed to look? We have to look on the contraction. So it is normal contraction. This is called a hyperdynamic contraction, and this is called a poor contraction. And another thing, it is we are supposed to look at the any fluid in the, around the heart. So it called a pulmonary pericardial tamponade, and we are supposed to look on the RA-RV. These are the objectives. So the rush protocol should be focused on the objectives. Then another area we are supposed to look on the HIMAP, it is called IVC. So how we have to assess the IVC? IVC we have to be assessed in a longitudinal view, and the pointer should be towards the head end of the patient. So we'll call it caudally. Sorry, cranially. The pointer should be cranially. And here we can see this a blackish. So this black pointer is available. This pointer is available. So here we can say this one is called IVC. So it is directly attached to the right atria, and we can see a small vein here. It is called hepatic vein. So it is a normal scenario where we will expect collapsibility, that should be that will be collapsed during inspiration and expiration. That the variation you can see, it is less than 50%, up to 50% we will call it as a normal, and more than 50% we will call it as it is collapsed. So here you can see that the depth it is decreasing, and it is somewhat it is called a kissing type of IVC. So that we can see in hypovolemic shock and early sepsis. So these patients will show good response to the fluid therapy. And what about this thing? Here we can see that there is no movement of the IVC. The IVC is fixed, and we will call this as a plethoric type of IVC. Though this type of IVC we can see in cardiogenic shock and obstructive shock. Then another thing, we are supposed to look on the any fluid inside the abdomen. So where all areas we are supposed to look, it is called a right upper quadrant view. So it is here we can see the liver, and here is the kidney. So in between the liver and kidney we know that we have a Morison's pouch. So Morison's pouch is the most dependent part of the abdomen. So whenever there is a blood in the abdomen, that will be deposited, or it will be that located on the right upper quadrant area. So here we can see that liver and kidney, in between we can see a blackish color. So that is called fluid in the abdomen. This is the Morison's pouch. The fast view we are look on we already discussed about the cardiac view. So cardiac view we supposed to look on the 3 areas. So we will get 4 images. So here we have 4 views and 4 images. So already we discussed about the right upper quadrant view. Here we can say left upper quadrant view. Left upper quadrant view, we can see a liver and spleen. So here we are looking on the splenorenal area, splenorenal ligament. So here we can see that that blackish colored area between the liver, spleen and kidney. So that is also showing a fluid in the abdomen. That is another area of another dependent area in the abdomen. So the another thing, it is called a pelvic view. Here we can see that this one is the bladder, and between the bladder and the rectum there is no fluid. So here we can see that there is a fluid, black colored fluid in the abdomen, in the pelvic region. Yeah, so it is also showing a positive fast or what is a fluid in the abdomen. So another area we are supposed to look on the fast examination, it is subxiphoid view. We already discussed it with the cardiac views. So where we are supposed to look on any fluid in the heart or fluid in the pericardial region. So now there is HIM we already discussed, and A and P's are remaining. So A means aorta. So we have to look at the aorta. So how will you identify the aorta? Here the aorta, when just look at the probe showing that pointed edge should be towards the right side of the patient. So here we can see there is two holes, two black colored structures, this and you can see this one and this one. So at the right side of the heart, right side of the image will be IVC, and the left side should be a aorta. So another landmark, we can see that some shadows over here as compared to here. That is because of the spinal shadows. So we have to look at the aorta, and we have to look at the structure of the aorta. We can discuss the abnormalities also. So here you can see that this one is aorta, and it is showing an outer margin, and an inner margin. So it is because of the thrombus, it is formed around the walls of the aorta, and it's inside the aorta. So it is showing a false lumen and it is a true lumen, and it is we can see an aortic aneurysm, and here you can see a flap inside the aorta. So that is we can see in aortic dissection. Both cases the patient will be in shock, and we have to identify these patients and we have to intervene immediately. And another last thing, it is in HIMAP, it is pneumothorax. So how we have to look at the pneumothorax? So pneumothorax, we have to check the lung area. So in lung area we have two methods. It is called, one is called the 4-zone method and 8-zone method. In a patient is in a shock, we can use a 4-zone method, where all things we are supposed to look. This we have to make a line in the perpendicular to along the nipple and the bilaterally and the parasternal area. So the distance between the first area between the upper part of the right lung and the second part, it is lower part of the right lung, and third will be in the left side, so upper part of the lung, and fourth will be in the left lower part. So we have to identify the areas with the landmarks, and we have to look for the any pneumothorax. So how will you identify pneumothorax? Here we can, after placing this, just look at the probe orientation. That should be longitudinally, and the pointer should be towards the head end of the patient, will call this cranially. And just we have to look at the image. So here we can see some whitish area, so it is called pleura, and it's some the hand crawling movement, it is happening there. So it is called an hand crawling movement. It is showing normal lung function. It is because of the normal lung function we can see that movement, but here we can see that movement. Yeah, here that the area it is still but not moving. So that is an indication of pneumothorax. So how we can confirm it is by, there is some sign we call it as a barcode sign. So place on probe on that same area and just press the M mode. So we are changing the 2D mode to M mode. We can see a pictures like this. It is called a barcode sign. So normally we can see a seashore sign. So that can be an important questions in many entrance exams and all. So you have to know that pneumothorax, after identifying pneumothorax, how do you confirm? Confirm by ultrasound by placing, we are changing the 2D to M mode. We can see a barcode sign, and normal we can see a seashore sign. So how will you interpret? From the heart we are looking on the hyperdynamic, poor contractility things. So we have to categorize that by this column. So we have, our aim is to identify the hypovolemic, cardiogenic, distributive or obstructive shock. So in hypovolemic shock, the heart will be in a hyperdynamic state, and the IVC showing a collapsing. And Morrison's pouch may show fluids. So Morrison's pouch fluid indicate that patient may not have a adequate intravascular volume. And the aorta, we have to look for the, in a hypovolemic shock we have to look for the dissection or aneurysm, that also will leads to the hypovolemic state. And the when we are looking at the pneumothorax, we will not get any pneumothorax in a hypovolemic type of shock. And the cardiogenic shock in heart we will get a poor contractility, the IVC is maybe plethoric, and the Morrison's pouch may be normal, and the aorta will be normal, and we can identify any pneumothorax in cardiogenic shock. So then we will call this as cardiogenic type of shock. And distributive shock, so in early stage of distributive shock we will get an hyperdynamic heart, later it become poor contractility, and the IVC will be normal or collapsing in distributive type of shock, and the Morrison's pouch also may be normal or positive in distributive type of shock, and aorta and pneumothorax will be normal. Coming to the obstructive shock, the obstructive shock we have to look for the already discussed in heart, we look for the RA-RV dilatation, right atrium, right ventricular dilatation, and we are supposed to look for the pericardial tamponade. So it is a fluid around the heart. And the IVC for them it is maybe plethoric, and Morrison's pouch will be normal, aorta may be normal, and in pneumothorax, in some tension pneumothorax, that we can see a pneumothorax also. So in distributive shock and obstructive shock we have a three major diagnoses called pulmonary embolism. In pulmonary embolism we will get an RA-RV dilatation, and pericardial tamponade we will get a pericardial, large pericardial effusion, and tension pneumothorax we can get a pneumothorax also with the ultrasound. So what are the emergency intervention we supposed to do with first? Rush protocol. So if we identify this hypovolemic shock, it may be hemorrhagic, maybe because of the blood loss or maybe because of the fluid loss. So if it is because of the blood loss, we have to use blood transfusion and bleeding control. It is the primary intervention we are supposed to do. In a hypovolemic shock, we have to correct the volume by fluid resuscitation. In cardiogenic shock, it can be because of the acute coronary event, or maybe because of the non-coronary event also can cause a cardiogenic shock. So if it is a acute coronary event, it is causing the cardiogenic shock, we have to do a primary coronary interventions. With or without inotrope support, we are supposed to do a primary coronary interventions. And if it is not because of the any acute coronary event, we have to initiate on inotropes, and we have to support the cardiac function. So if it is obstructive shock, we already discussed, it can be pulmonary embolism, tension pneumothorax, and pericardial tamponade. If pulmonary embolism and patient is in shock, we have to use thrombolytic treatment. If a tension pneumothorax, we have to use a nasal decompression, and pericardial tamponade. So we can use a pericardosynthesis as an emergency intervention we are supposed to do based on the rush protocol. And distributive shock also can be a septic shock, anaphylactic shock, and neurogenic shock. How will you get this idea about it? It can be septic shock or anaphylactic shock or neurogenic shock. We have to ask the history, we have to take the history. From the history we will get a clue about this type of shock, because all these shocks will show the features of distributive shock. So the treatment is different. Septic shock, the fluid and antibiotic is the initial treatment, and anaphylactic shock, fluid and adrenaline is the treatment of choice, and neurogenic shock and fluid and inotropes. These are the treatment options we can provide with our clinical diagnosis and the rush protocol based identification of the shock. So the rush protocol will take only 5 maximum is 2 to 5 minutes. So within 2 to 5 minutes we can identify the type of shock and we can initiate treatment for the patient well-being. So this is commonly used intervention in emergency department, and it is showing a good impact on the management of sepsis and shock also. Thank you very much.